All right, chapter 15, recording 3. So, talking about respiratory conditions. So, now we're on to asthma, hay fever, and anaphylaxis, which kind of all result from an allergic reaction to an inhaled, ingested, or injected substance. Sometimes we truly have no idea what causes this, what triggers the immune system, but they all pretty much react the same way. So, asthma itself is an acute spasm of the bronchioles that's associated with excessive mucus production and swelling of the mucus lining of those respiratory passages. Approximately 25 million Americans have asthma at any given time. Asthma affects all ages. It's most prevalent in children 5 to 17 years of age. Produces a very characteristic wheezing, which is caused by those partially obstructed airways. Wheezing is a sound that's indicative of lower airway obstruction, and typically you can hear it without having a stethoscope on if they have some airway obstruction. Asthma attacks may be caused by allergic reactions to specific foods or other allergens. A lot of times, if people have asthma and they know that they have asthma, they have an idea of what their triggers might be, and so they try to avoid them. It's obviously not super easy to avoid everything, and then sometimes they can be triggered by something that they had no idea was around. Attacks may also be caused by severe emotional distress, exercise, respiratory infections. In its very most severe form, you can get anaphylaxis. Oftentimes, though, just mild reactions are going to cause what the common term is hay fever. It's like cold-like symptoms. It's that runny nose that you get, sneezing, congestion, sinus pressure. Oftentimes, these allergens are pollen, dust mites, and pet dander. Patients with hay fever tend to be atopic, is what we call it. That means that they're more likely to have other allergies on top of just hay fever. But if they go into a true asthmatic attack, or they are exposed to something that they're highly, highly sensitive to, they can have that anaphylactic reaction that we've already talked about. Signs and symptoms are very similar to asthma, but the airway can actually swell so much that you can get total obstruction. Patients may or may not be aware of this high sensitivity. If they are, typically they'll have an EpiPen, which, remember, Epi is the treatment of choice. Oxygen and antihistamines are follow-up, but Epi, first and foremost for anybody that's experiencing anaphylaxis. A spontaneous pneumothorax. So this is when you get accumulation in the air of that pleural space where there isn't supposed to be a whole lot of air. Most often caused by trauma, but it can be caused by medical conditions as well. So the vacuum-like pressure that's in the pleural space that keeps the lung inflated, when that gets disrupted, air escapes into the pleural cavity, the negative vacuum is lost, and you get all this air that collects and pushes pressure on that lung. And it may be mild, it may be severe. Oftentimes, patients will have infections or weak lungs themselves. Some people are just born with weak spots in their lungs, which makes them more susceptible. People with emphysema or asthma are at significant higher risk. The population of male that tends to really experience this more often than not is super tall, very thin males. A patient with a spontaneous pneumo may become dyspneic, might complain of a pleuritic type chest pain, which is like a sharp stabbing pain on one side, typically is worse with breathing or certain movements of the chest wall. And sometimes there are decreased or absent breath sounds on the affected side. And you can see in this picture, you've got a wound in the lung itself, and all of this pleural space is filled with air, which is actually collapsing that lung. Now, when we have fluid instead of air, we call that a pleural effusion. This compresses the air, causes dyspnea just like anything else, but it's not air. It's some sort of fluid that's caused by irritation, infection, congestive heart failure, can be from cancer. Patients often feel better sitting upright. You have several lobes to your lungs, and if you can situate that fluid so it only obstructs the bottom, then you have the upper lobes with which to breathe. If you lay them down, now all of a sudden that fluid is going to fill that space and start affecting all of the different lobes of the lungs. Obstruction of the airway through mechanical means. This means something gets in there and obstructs the airway. The most common is that tongue. And so that's why we have to position the head appropriately to try and pull that tongue out of the back of the airway. Otherwise, it could be a foreign body obstruction that we need to try to remove. A pulmonary embolism. An embolus is anything within the circulatory system that moves from its point of origin to a distant site and lodges there, which then obstructs blood flow past that area. This can be fat, this can be blood clots, this can be air. Just has to be large enough that it either partially or completely cuts off circulation downstream of the clot. A pulmonary embolus is a clot that circulates through the venous system and may be the result of damage to the lining of the blood vessels. If that person has a tendency to clot their blood very quickly, your body can't keep up with it, and it can end up traveling and resulting in blocking slow blood flow in a lower extremity. Can also lead to blood clots that end up traveling up to the lungs. This is often the result of long-term bed rest or immobility. Somebody that already has problems with clotting in their blood, if they sit on an airplane for far too long, that could lead to a pulmonary embolus. Signs and symptoms include dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, kind of depends on how bad it is, cyanosis, acute chest pain, and hemoptysis, which is coughing up blood. With a very large embolism, you can get complete obstruction of the output of blood from the right side of the heart, which can result in sudden death. So pulmonary emboli can be very, very life-threatening. Hyperventilation, this is overbreathing to the point that the level of arterial carbon dioxide falls below normal because you're breathing off far too much. This can be an indicator of a life-threatening illness, or it can be a response to a highly stressful situation. The body may be trying to compensate for acidosis when you get too much blood that or CO2, excuse me, that builds up in the blood. Remember, CO2 within the body is synonymous with acid. Your body is trying to blow that off. However, if it's not, and your body is just going to town trying to blow off a lot of CO2, it can result in the exact opposite. So alkalosis, and you could have a buildup of excess base in the body fluids because you're blowing off all of that acid. This can cause symptoms of hyperventilation syndrome, also commonly known as a panic attack. You get anxiety, dizziness, numbness, tingling of the hands and feet, which is actually called carpal pedal spasms. That's when you start getting that tingling and then they go into painful spasm. The decision whether or not hyperventilating is caused by a life-threatening illness should not be made outside of the hospital. You want to try and talk to your patient down, instruct them how to slow down their breathing. You may have to give them supplemental oxygen, transport them to the hospital. I've said several times we don't have them breathe into paper bags anymore. We found out that's not exactly great for them. Environmental, industrial exposures, pesticides, cleaning solutions, chemicals, chlorine, other gases may accidentally be released at industrial sites and then inhaled by the employees at those sites. Many industrial sites have their own medical teams that will respond and take care of them, but they often don't transport, so they'll end up calling us instead. Some of those more common poisonings, carbon monoxide poisoning. It's odorless, highly poisonous. It's the leading cause of accidental poisoning deaths in the United States. Carbon monoxide is a waste product that's produced by fuel burning household appliances, and it's present in that smoke. People who have carbon monoxide poisoning often complain of flu-like symptoms and dyspnea, even though their O2 saturation is going to be high, because carbon monoxide likes to bind to hemoglobin 100 times more than oxygen does. So they act like they have enough saturation in their blood. It's just saturated with the wrong thing. Make sure that you don't put yourself at risk if you have several people that are exhibiting similar symptoms in a relatively close area. Know that it's probably something that you don't want to expose yourself to. High flow oxygen by non-rebreather is the best treatment for conscious patients. Just try and overload their system with some oxygen to knock that carbon monoxide off. If they're unconscious or have an altered level of consciousness, you may need to fully control their airway for them using a BVM to try and get enough oxygen in. Patient assessment is just like everything else, seeing safety first and foremost. Use standard precautions and PPE. Make sure that you rule out the possibility of infectious disease or a toxic substance that you may need to protect yourself from. You want to go into mechanism of injury and nature of illness, figuring out why they called 911 themselves. You're going to ask the patient, family, and or bystanders just to try and get more information. Then you'll go through your primary assessment. Remember, primary assessment is finding those immediate life threats and forming an overall general impression of the patient's overall level of distress. Note the age and position of the patient. Are they calm? Are they anxious? We want to determine their level of consciousness on that AVPU scale, and then ask them about their chief complaint. We go into ABCs, make sure the airway is open and self-maintained and that they're breathing adequately. Again, that's not just assessing, are they breathing, yes or no, but what's their rate, rhythm, quality, what are their breath sounds as well. Open the airway if you need to at this point. And then is the air going in properly? Does the chest rise and fall with each breath? And then is that adequate for the patient's age? The picture on the screen shows where you would listen for breath sounds, 4 on the front, 6 on the back. You want to try and listen over a bare chest if you can. You want to check both the left and right sides of the chest and then compare them to each other and listen to breath sounds for a full respiratory cycle, because you may have sounds on exhalation that you don't have on inspiration. Circulation, check for shock and bleeding, assess capillary refill, especially in infants and children. You're going to look at skin color, temperature, and condition. Then you want to assess the pulse rate, rhythm, and quality, just like you do for respiratory rates. You want to indicate if there are any possible life threats and control major life-threatening bleeding, and then you're going to come up with your transport decision. If they have problems with ABCs, have a poor general impression, you know that they're sick, they're unresponsive, there's a potential for hypoperfusion or shock, chest pain associated with low blood pressure, severe pain anywhere, and then excessive bleeding, you want to go ahead and transport the patient as soon as possible, address any life threats, and then you can do the rest of your assessment in the rig on the way to the hospital. I will go ahead and stop right there.